Dr. Maldonado will start, and if that's okay, Dr. Goldschmidt, or do you have a time crunch as well?
I think I fixed my problem, but either way.
Or yeah, I mean, it's up to you. I mean, we could certainly. I'm happy to switch roles and help moderate your case, and then when Jen comes on, I can do Dr. Maldonado's.
Oh, well, why doesn't Daniela go first so you can do it with her?
Yeah, I'm okay either way.
Okay.
Okay.
And of course, worst case scenario, if Jen is not able to join, we can have Dr. Froman step up and be the moderator like he did for many years.
Always happy to do it. We have two great new chairs, and I think Jen will join us as she always does, and she's fabulous, but happy to help no matter what.
I'll start sharing my screen.
Wonderful.
Can you guys see it?
Yeah, there it is.
Looks good.
All right. Let me know when you'd like me to start.
Nope. Go ahead.
Okay. So my name is Daniela. I'm a first-year Civilary Fellow at Johns Hopkins, and I work with Scott Newsom and Ellen Murray primarily, and very happy to be here. So today we have the case of a 67-year-old woman with history of hyperlipidemia, and she also has bilateral cataracts. She's recently had cataract surgery in her left eye the month prior, and so she complains of 2 days of burning, itching, glare, decreased color saturation, and difficulty reading fine print with that same eye that had the cataract surgery, the left eye. Her case goes back, this is the kind of the current presentations, but her case has an 11-year span, so we're going to briefly go through her whole history. So in January 2009, so this would be her presentation, 55-year-old woman with no past medical history who presents with a 10-day history of decreased vision in her right eye, as well as pain with extraocular movements. On ophthalmologic exam, she had optic disc swelling, then she had a couple of areas of hemorrhage, RAPD, and then decreased color vision, and also in that right eye. Visual acuity was 20/50 in the right eye, and then 20/25 on the left eye. She was diagnosed with anterior optic neuropathy, and then so she had some of like basic workup that was unrevealing, including anti-aquaporin 4. And this is her MRI, and on the left we can see a T1 post contrast that shows more than 50% involvement of her optic nerve. And is there anything, and this also involves the chiasm, is there anything else you see in that MRI that catches your attention?
It's like a drop of enhancement in the other eye.
Definitely. She also has a prechiasmatic involvement in that contralateral eye. So
maybe Daniela, even in the eye. Could be an artifact, but it's a little higher up.
This one?
Not on the other side.
Cursor?
No, yeah, I know, but I'll try the other eye. There's something over here. You can't see my cursor. There you go. Is that an artifact, or that may be real?
I think it might be an artifact. Radiology did not comment on this. I'm not able to say if this became a question back in 2009. Maybe Dr. Newsom can chip in.
No, I don't think there was anything specific relevant to her presentation.
Okay.
But I also wanted to point out that this eye has this is quite obvious, but this eye also has some prechiasmatic involvement. And then this is her MRI of the spine. Her spine looks clean. She has some degenerative disease, but outside of that, there were no signs of short or long segment myelitis. She had a lumbar puncture. Her glucose was 111. Her serum glucose at the time was between 150, 160. Protein was 32, RBCs 738. Then in tube 4, this became 8. 1 to 2 white blood cells, 4 oligoclonal bands unique to the CSF, and IgG index was 0.8. She had a CT of the chest, which was unrevealing for either lymphadenopathy or signs of TB, and she made the personal decision of not receiving steroids. However, since this was left untreated per her decision, her vision continued to worsen over the following month to the point that she only had hand motion in that right eye, and she also had worsening of optic disc swelling and hemorrhages. At this point, she agreed with receiving steroids, so she got IV methylprednisolone 1 gram per day for 3 days. And then she received prednisone 60 milligrams daily for 11 days, followed by a 6-week taper. And her vision in that right eye improved to 1 to 2 over 200.
Mm-hmm. Hey,
So,
Daniela, this is
yes.
Elliot. Could you go back to the first slide, the one behind? I just want to emphasize what you've, no, keep going. You had it. The slide right before the last one. Yeah, right here. Just to point out, just in that right eye, how swollen that optic nerve is. And when you come back to that orbital apex, that annulus of Zinn, that circle where the tendons, the nerve, the blood flow, both arterial and venous outflow, are moving in this area, that you can see the possibility that as this gets bigger, the prospect of potential choking on that optic nerve. So 2 features. One is that this is not a short skip like a retrobulbar, a typical MS optic neuritis. This is long segment, like you might see, for example, in NMO, maybe even in MOG, you could see it. But my big concern is the compliance, pressure-volume relationship of that optic nerve at the apex. And on the other side, you can tell the apex, there's some effect, and I think Bob rightly points out, there's some little areas that may be enhancing in the left eye. But you can see that orbital apex is, at least at this point, is wide open, whereas the apex, kind of like an ice cream cone, you can see at the bottom, that optic nerve gets a little bit bigger. You're going to have a bigger problem, which is you're going to embarrass the blood flow within that optic nerve, and that'll create a disaster. So just wanted to point that out. And for the trainees that look at that dot in the center, you expect to see that dot. That's the hypothalamic pituitary infundibulum, which has no blood-brain barrier. So it's essentially always going to enhance with gadolinium. So just a few pointers there. And and this patient, if you look at this image in the center, that may be a sphenoid sinus inclusion cyst. I'd have to look at more cuts. But other things are raised in suspicion if we have sinus involvement and other things. So just want to let you know it's not totally immaterial. I had a patient who had a fever of unknown origin, and boy, she got this giant workup. Her MS was worse. She had her UTOF. She couldn't walk. And sure enough, she had this except in the frontal sinus. Everybody thought that was a joke. I had been watching it for a while. I had the maxillofacial guys unroof it and take it out. It was an infected abscess polyp the size of a silver dollar. About 24 hours after we took it out, her FUO resolved, which had been going on for months. So these are the things that we get. We want to, at least make some remark about. I don't know if this is relevant or not, but clearly that's not a aerated sinus as it should be.
Dr. Maldonado has a sort of a pause slide to go through the differential as it relates to sort of the story.
Great.
Great. Yeah, and definitely that sphenoid sinus came up. I did not point it out, but we can talk a little bit more about that. She did end up seeing ENT. That we can, after we go through the differential, kind of I'll mention what happened with that.
On the right image, you also have an inferior maxillary sinus inclusion with a level that's the patient's right on the frontal image, that right there. Okay. All right, I'm done. Just wanted to point it out. Okay.
No, thank you. Thank you. Very important. Yeah, and I definitely agree that that long segment lesion, along with the bilateral optic nerve involvement. Definitely those are red flags.
And listen, Laura Balser's on the line here. I can't let you get away with that without saying that. She's like, you know, she's like my godmother of neuro-ophthalmology. So if you show that and Froman doesn't say anything for a while, she's gonna chime in. So I have to do that. Wonderful.
I think we finished with this slide. So her right eye improved from hand motion to 1 to 2/200 visual acuity. So after this, in August 2009, she had mild pain with extraocular movements on that right eye. So she was diagnosed with recurrent anterior optic neuritis. She declined steroids again. This time she had serology recent. She had an anti-SSA that was borderline high, and she had an elevator ACE in the serum. MRI showed again increased thickening and diffuse abnormal signal enhancement of the right optic nerve. And then in November 2009, she had an ER visit due to painful extraocular movements in the contralateral eye, that left eye. So she had, at that time, hand motion in the right eye, 20/20 -2 on the left, and then she had that right RAPD. Slit lamp examination, now concerning for left optic neuritis, and MRI of the brain showed diffuse enhancement of the right optic nerve with slight thickening and enhancement of the perichiasmatic left optic nerve. She got IV methylprednisolone this time, followed by oral steroids 70 milligrams daily, and she had complete resolution of the episode on the left eye. She also had a PET scan in December of 2009 with no evidence of lymphoma or malignancy. And that's important to, that's going to become important later on. Any differential diagnoses that people are thinking of at this
Yeah,
point?
why don't we do like prior webinars? We'll start with the fellows, and then we can sort of work our way to the faculty. And especially we have great neuro-ophthalmologists on the line who may be able to educate us on what was seen in the direct fundoscopic exam with the hemorrhages. Does that help, you know, narrow down the diagnosis and others? So, fellows, what do you think?
So I would think what Dr. Froman was suggesting earlier, like anti-MOG disease, potentially like sarcoidosis.
I agree too, like with the bilateral involvement, it's pretty severe. Granulomatous disease too. I mean, her Sjogren's antibodies were a little bit high, so that I think other autoimmune disorders could also be considered. And then paraneoplastic causes as well, like CRMP5. And then Cryon, although it sounds like we have maybe like one episode she was treated with steroids, but you know, Cryon could also be considered too.
And Jackie, why would you think about that based on sort of demographics?
I think age too, maybe perhaps, and I think she had, I can't remember, did she have hyperlipidemia?
Not at that point.
Not at that point, okay.
Not diagnosed, at least.
Okay.
And I'll follow up on that comment. What for the fellows and thinking about the differential, how does the age impact what you think about here? She's 67, correct?
Correct. At this
Well,
point, she's 55.
Oh, at this time she was 55. Okay.
But still, it's a good point, Jen.
Yeah.
I think, you know, thinking about the demographics that someone presents with is certainly important to consider. Not that it's an end-all be-all, but I think it does help determine what are next steps with the workup. You know, she's not a 20-year-old where some of the workup that she underwent probably is a little excessive, potentially. So what do people think, fellows think about that in general?
Maybe with their age, would you think you get to work up for something more vascular as opposed to inflammatory?
Certainly that comes in. I think I heard from someone else a perineoplastic process, which, you know, over the age of 50, 55, who, you know, comes with sort of these longitudinally extensive optic neuropathies. have to be concerned about a underlying malignancy potentially. Not always the case, but I think it's very important. Someone mentioned anti-MOG, and then Elliot mentioned NMOSD. On the MRI, what are features that may go for those diagnoses versus, maybe other conditions? MS, I think, is pretty obvious. This is likely not MS, right? It looks, doesn't appear that way. Person's a little bit older as well. But what features would make you more concerned about this sort of MS mimickers?
So I think this doesn't look like an MS optic neuritis, just, this longitudinally extensive involvement of the optic nerve. So this would definitely make us think more in the NMOSD or MOGAD category. I think the involvement of the anterior optic nerve, would definitely be something to point us more to MOGAD. Also that, with that course with the bilateral sequential involvement, first the right, then also the left, also that contralateral involvement in this initial scan as well with that pre-chiasmatic lesion. Both, could both be still like aquaporin negative NMOSD, but it's very suspicious for MOGAD, just like how it's looking at the longitudinal extensive involvement of the anterior optic nerve.
I think
what about the posterior portion and the chiasmal involvement? Any comments with that?
I think that too, the chiasmal involvement and the perineural enhancement, I think, is something to, like the perineural involvement for MOG-associated optic nerve disease.
What else should be on your differential if you see perineuritis, perineural involvement? You guys are right. You are right on track thinking, this is not MS once you see a perineural involvement. But what else, in addition to MOG, do you think you need to think about? Can NMO do this? What other autoimmune, inflammatory, infectious, neoplastic, what else can cause perineuritis? What's your differential for perineuritis?
Optic nerve gliomas or other malignancies can certainly cause the perineuritis.
And infections certainly can, but I think we're hearing a story of something that's been going on for a very long time. So that might guide us away from infection. Other thoughts from fellows before we have the faculty?
I think someone had mentioned neurosarcoid as being a potential, and I was pointing out sort of the posterior and chiasmal involvement because I think that, at least in my experience, you don't often see that with MOGAD. I think it was mentioned anterior portion, perineural involvement. You'll think about MOGAD, but when you start to see the posterior involvement, chiasmal involvement, not that MOGAD can't cause that. But you start to think about NMOSD, neurosarcoid, perineoplastic etiologies. Curious for neuro-ophthalmologists of the group, can you educate us on sort of the hemorrhages that we're seeing? Does that give us any helpful hints in what this could be?
Can I ask a quick question before we go to the neuro? How about IgG4 related disease here? For the perineuritis specifically that Jen is mentioning.
Yeah, I think that's a great thought, great comment. It seems like the IgG4, related disorders, whatever you want to call it, can do what it wants. It's like the sort of syphilis of the day, or the lymphoma of the day. So it's certainly something that you would want to check. And I feel like she's been checked a couple of times for that.
Well,
great.
Has she been checked?
Yeah.
Yes.
How? With the biopsy?
Oh.
If you can't rule it in or out with serum IgG4, cannot.
Sure.
And you've got this thing sitting there that Elliot mentioned,
Mhm.
and then another one lower down. Usually it's more diffuse thickening. I have one patient who's had perioptic neuritis and difficulty with eye movement in the whole back of that eye, who has granulomatosis with angiitis, so-called, we don't want to use his name, Wegener's disease. So an ANCA might be of interest, and biopsying that thing sitting there, if it is, part of the old FUO was, Sutton's law. So where the money is, there's something sitting there that's biopsyable. So something to think about. I'm not saying it is granulomatosis with angiitis, but you got two sinuses that don't look very normal. May get perioptic neuritis, as far as from what I've read and from what my patient has. I don't think they get optic neuritis. So I don't know about the hemorrhages in the fundus. Although, as Elliot points out, certainly if you're starting to get backup of vascular structures, that could be cause of that.
Yeah, I don't know, Dr. Balser, Dr. Coletta, Dr. Graves, any additional comments on that?
Yeah, the hemorrhages really put you out of the category of typical demyelinating optic neuritis. As you know, I'd be curious to see, were there other retinal findings? Was there any uveitis or other evidence of ocular inflammation? You also describe a process that was smoldering over 10 years or recurrent over a 10-year period. Is that correct?
Yeah,
she was 67 and then was 55 before.
That is correct.
Yeah.
Gotcha.
Yeah, and I think Danielle is going to go through
Thank
the formal history over time. Yeah.
That is correct. And she did not have a biopsy of at least anywhere in her brain. She did have a lip biopsy because of the borderline high SSA, which was not consistent with Sjogren's. And again, we did have a PET scan to look for malignancy. She had it done one time.
And I'll agree, of course, with Dr. Balser that the hemorrhages put up a red flag for MS, but can sometimes be seen with NMO, and has also been reported for MOG. So really, really severe edema, they have been seen in those conditions, but it certainly also raises a red flag to think about things outside our usual trio of NMO, MOG, and MS as well, and make sure we've thought about that.
Hey, Daniela, why don't you move on and give us more of the history?
Okay. So in March 2010, she was started on CellCept at 1 gram POVID. This was slowly up-titrated. So approximately a year later, she had just a routine ophthalmology follow-up visit. Her vision was unchanged in the right eye. Her vision in the left eye was 20/30. It had been a little better prior to that. And then her color vision was somewhat decreased. She was asymptomatic. And due to this reason, she received IV methylprednisolone for 3 days. And then her oral prednisone was restarted at 20 milligrams daily. CellCept was increased to 1.5 grams BID. And after this, her vision returned to baseline. Again, on retesting, she was asymptomatic. About 3 to 4 months later, she complained of difficulty reading small print with her left eye. And so she had another episode of optic neuritis in that left eye, received again IV Solumedrol for 5 days, and then she was started on prednisone 60 milligrams daily. Would anyone like to comment on next steps, or do you feel like she should continue on CellCept after this?
Can I ask you one question? The prednisone, by the time she had the other attack, was the prednisone, was she still on 20 milligram or?
The April attack?
The August attack, was she
no.
on 20? Or
No, I don't believe she was still on prednisone.
Okay, so would you say that this attack corresponded to her being completely weaned off of steroids?
It's possible. Mm-hmm.
Yeah, it's always challenging. I don't know what other people do with the steroids, how long the taper is. I mean, when you're transitioning people to a non-steroid sparing agent, we'll often do at least a couple months maybe even longer, depending on sort of the preceding history. So CellCept obviously takes a while to build up into the system. And so I don't know what, for those of you that use CellCept and maybe some of the other medications that take a while to become effective, what are people doing?
In myasthenia, I wait at least 4 to 6 months before I taper. Not before I get rid of it, before I taper. So we know from some stuff we published in myasthenia, and then Jackie Pallas and John Newsom Davis, is that you can take 6 to 12, 14 months to get full azathioprine. And then the failure of the CellCept studies in myasthenia were based on the idea that people thought they could solve an equation with 2 unknowns. So since everybody, quote, knew, end quote, that CellCept was stronger and faster, maybe for transplant that's right, than azathioprine, they did the same study that Jackie and John did, except they did the taper over 1 year, and it didn't work. So there's 2 possibilities. It either doesn't work, or it doesn't work any faster than azathioprine. So I'm very hesitant to taper steroids too quickly when I have a patient that I'm waiting for the azathioprine or CellCept to kick in. Cyclosporin, which I'm not sure makes much sense here, does work a little quicker. So sometimes in myasthenia, I'll use that, although I'm not a big fan of tacrolimus and cyclosporin, especially in people who might get hypertension and headaches and hirsutism and young women and so forth. But I think we see too many people where the steroids are dropped down because, and then the other thing we see is somebody's on CellCept or azathioprine for 4 months and it's, quote, not working. Well, of course not.
So I would agree, probably minimum 3 to 6 months, depending on the etiology. If it's an inflammatory disorder or orbital pseudotumor, things like this, probably, if you don't know what you're doing or what you're treating exactly, probably 3 to 6 months while you put a broad spectrum agent on. I was wondering, when the CellCept was increased, did you check a mycophenolate level? Because I've found that to be helpful in my patients I monitor on mycophenolate. Sometimes I'm quite surprised by the levels when I check them, or was it more the breakthrough that motivated? And I'm sorry if I missed that, if you did say that, but did you check the level of mycophenolate?
It was a breakthrough that motivated the increase in dose of CellCept. I do not believe I saw a CellCept level, but Dr. Newsom might correct me if I'm incorrect.
It was a breakthrough.
By the way, one other quick point that Elliot likes to make, so I'll make it for him, is you got to remind the patients an hour before or 2 hours after meals. Because if they take it at different times or with the meal, your absorption is going to be all over God's creation, and then you do need levels. But if you should take it an hour before or 2 hours, and I remind the patients every time they're in clinic. They say, I know I take it that way. I said, good. Convince me. So reassure me, rather.
Yeah, no, that's a great point. And I believe she was taking it as prescribed and as recommended. And just to remind everyone, this additional bout of optic neuritis, just because it's a long timeline, was a little over a year after starting CellCept. So this is not, a month out. So in terms of the, level within the blood, even though we didn't check the level, which I think is a great idea. And hindsight's always clear, probably would have checked it now. At 1,000 BID, we do have quite a few people under good control, but I think these are all really good points to consider. Okay.
Should I continue? Should I move forward? Okay.
Yeah. Mm-hmm.
So she was started on rituximab in September 2011. So in March of 2012, she had another episode of optic neuritis. She was adherent to rituximab treatment. Any thoughts of what could have caused for this additional episode of optic neuritis after having received, already one full cycle of Rituxan?
So what about the fellows?
It's always possible. It's always possible that people can repopulate early. So you check like a count level. And then I think somebody added in the chat already, If this is MOG disease, we're seeing people break through rituximab like crazy, so that wouldn't necessarily be unexpected. I feel like the next question is going to be, so what do we do now? And so this would probably be a point where I would, if she hasn't gotten a PET scan recently, or if you can't get insurance to do that, at least a CT, chest, abdomen, and pelvis, and think about, again, resending I think if we're in 2012 now, we can resend NMO. We don't yet have our good titer for MOG.
Yeah, she did have NMO anti-Aquaporin 4 resent kind of every time she went into the emergency department. That one was repeatedly negative. Her last PET scan at this point, or her only PET scan, had been in 2009, but you're right, this is what happened with her. She actually repopulated. So after she had this bout of optic neuritis, she received her following rituximab treatment, and actually she remained stable until now on rituximab. So it seems like what happened was really the early repopulation. So in summary, we have at this point a 57-year-old woman with several episodes of optic neuritis, 3 in each eye for multiple reasons. Perhaps cell set failure, then when first initiating treatment with rituximab due to CD19-20 repopulation, and then also prior to all of this, before she was started on a maintenance agent. So her baseline visual acuity after all these episodes of optic neuritis was no light perception in the right eye, and 20/20 - 2 on the left eye. And so here are just a few images of her OCTs. So as we can see, her average retinal nerve fiber layer thickness is pretty reduced bilaterally, even though one of her eyes has good vision and that she can report. The low contrast visual acuity would be a different story. And then also the same thing with her GC. Ganglion cell layer thickness is also quite reduced, especially in that right eye.
Just wonder the fellows if you want to comment on maybe the OCT differential when we think about MS versus NMOSD versus MOGAD. Is there anything that you guys think about when you sort of put the clinical and imaging together? Like what may go with either of those? I guess we could narrow it down to NMOSD and MOGAD.
So I think it's severely reduced in terms of the GCIPL thickness. It's very, very thin. It's bilateral, right worse than left. So again, just kind of tuning into the bilateral nature of it and the severity of, I guess, injury that has occurred. I definitely think NMO spectrum disorder is like pretty high up there. Perhaps a little bit more than MOG. And then for MS, I mean, again, oftentimes we see it more unilaterally, but on OCT, we can see subtle changes bilaterally as well, but often not as severe. So being less than the first percentile, often you get, obviously relating to age, like 60s, 50s, 60s, and this is 30s and 40s, which is pretty alarming.
I'm going to sneak in a question to quiz the fellows. One thing that's striking here is that the RNFL looks symmetric, but quite dramatic, different function and vision. And of course, there are ways to explain this, of course, but I think it's worth taking a step back and thinking, particularly in a challenging case like this, about other things that can cause a really dense central vision loss, and to think about whether we may or may not know everything about all the prior ophthalmologic exams. But do any of the fellows want to comment on when you see certainly this much RNFL loss, and I think we see pretty significant and asymmetric GCL loss, correct? But other comments that the fellows want to make about other causes of dense central scotomas that could be in an inflammatory, infectious, or neoplastic process that could cause a dense central scotoma in addition to optic neuropathy. May not be relevant for this case. Is there another structure in the retina that you want to make sure that you've looked at? You kind
I
of have
have to say on my typical OCT scans, I usually have a nice page with the macula on it. I don't know if that's what you're referring to.
Absolutely, and I think we're seeing part of that here when we see the GCL IPL. But I just wanted to point out that when you're thinking about conditions like this and you have severe vision loss and you're not exactly sure what the process is, to remember to check for other parts of the retina and not just in the optic nerve.
Yeah, I think you bring up an interesting point, Jen. I wasn't sure if you were going in this direction as well, with sort of the contralateral eye being actually pretty impressive with the preserved visual acuity, yet you're seeing such robust thinning. And, you know, with the differential, and this is one of the questions sort of leading people to, is that with MOGAD, there's this weird disconnect where you see profound thinning on OCT where the visual acuity is preserved with a lot of these patients. Now, obviously, this particular patient, the initial optic neuritis hit was quite severe and left her blind essentially on that right side. But it's something of interest, and I don't really understand the pathobiology of that, and I don't know if those that are smarter than me, the neuro-ophthalmologists, can comment on why there's this sort of weird disconnect. But at least for me and the differential, when I see this discrepancy, it raises sort of a flag to say, okay, could this be MOGAD also, based on that, you know, OCT versus visual acuity difference. So I don't know, Jen or Laura or Steve, if you're still on, Elliot.
I think we should, yeah, I know Laura's got a MOG study. Dr. Balser, Dr. Galetta have a MOG study coming out of NYU that is going to be multi-site. I don't know if you guys have more insights for us about the structure function, the different structure function correlation in MOG versus, say, MS.
One question I have is, has she had elevations in ocular pressure? Because certainly, you know, one of the points in the differential for preserved visual acuity and an optic neuropathy is some form of glaucoma. It sounds like she had swelling and this was steroid responsive, so that's not it. But if you are sent a patient who has, you know, profound RNFL thinning, but their central acuity and their color vision are intact, that's in the differential.
Yeah, I think that the MOG cases relatively spare the papillomacular bundle. These are the fibers that are small and they're dedicated to central vision. And it is curious that MOG tends to affect the perineural structures and, you know, probably does, you know, do a fair amount of damage, but spares those central cables of the papillomacular bundle. And as I said, there are different fibers. They're smaller than the other axons in the optic nerve. And so I think that that probably does account for the differences. But this case, I have to say, it's really a great case. I've enjoyed it so far. If I were to say the MRI findings would certainly vote for NMO, the hemorrhage in the back of the eye would slightly favor MOG over NMO. So it's really a very curious case. And then the failure with these drugs would support potentially MOG. So I'm curious what the end game is going to be here. But I think, you know, I would have been thinking about gamma globulin along the line here to treat the patient.
Just to save face with these giants of MS here, you know, this is 10 years she was stable on Rituxan, and it wasn't until recently that she had breakthrough activity that Danielle is going to take us through. Not that that helps, differentiate NMOSD from MOGAD. And at the time, of course, the antibodies that we have today, I don't remember when they became readily available, but it's only been in the past few years, I guess. But IVIG is certainly something we consider now, definitely. Even as first line, personally, if I see someone with MOGAD, I'm considering IVIG right from the start.
I agree.
That Mayo Clinic, admittedly, not prospective, that was their favorite, as I recall.
Yep.
The one that just came out from the Mayo people.
Yeah, John Chen group.
Right. Yeah. Right.
Okay, so Daniela, why don't you take us through to give a few more slides?
Of course. So in September 2020, she felt like her vision in the left eye was becoming more affected. She saw an ophthalmologist, she saw a neuro-ophthalmologist, and then she had a cataract in her left eye that had been determined to be worse, and it was so that was a reason for her to have worsening vision in that left eye. In addition to that, so she had some constitutional symptoms. She had a 25-pound weight loss over 3 months, and she did have this worked up with her PCP. Nothing really came out of that. Her white blood cell count had been consistently elevated to about 13,600, and just so we are clear on her Rituxan timeline, so she was due again in October, so the following month. She had cataract surgery of that left eye at the end of October, and she reported in November that her vision had not improved after her cataract surgery, and also she started complaining of paresthesias, which was completely new in her left fifth digit, upper right thigh, and then in her left foot. She did see us in clinic, and so she was recommended to undergo an MRI of the brain, C and T spine. This was on an ambulatory basis, and in the interim, while this was getting arranged, the following month, she contacted her ophthalmologist due to acute vision worsening in that left eye that lasted for that had been going on for 2 days. She was seen by her ophthalmologist, who sent her to the emergency room. Her physical exam in the ED, I could not find a visual acuity exam, but she had that known RAPD, and then on the right eye. And so she also had a left pupil that was minimally reactive, which was new. And then she did not have pain with extraocular movements. That was the only thing that was noted. Everything else was unremarkable in terms of her neurologic exam. So here again, she had anti-aquaporin 4 and anti-MOG tested. She had both, we tested it at Hopkins, and so she also had it sent to Mayo Clinic. She also had other workup that I list here that was not revealing, and she had another lumbar puncture. This time her red blood cells were in the 130s in both tubes, tube 1 and tube 4, and then whites were 10 and 10, mostly lymphocytes, and glucose was 96. Protein was normal. She did have some workup for infection, and she essentially we still felt like her diagnosis was consistent with NMOSD.
Can you pause it? So the red cells 137, 134, tube 1 and 4. Fellows want to make any comments about that? I know we're low on time, and anybody worried about the red cells? They're not going down.
It was a bloody tap.
Was it really bloody tap? Okay, but still with the bloody tap,
Maybe.
They should go down unless you re-hit another vessel, right? So that bothers me for NMO. I don't know
But Jen, if the needle is sitting on that vessel, and 137 versus, it's not going down, but we used to joke when we used to do red cell counts in a hemocytometer. count one square and multiply by a million because it's not very accurate. What we don't do anymore, because there's no microcentrifuges on the floor or in the ED, is we used to take a little bit of CSF yourself, put it in one of those little microcrit tubes, spin it down. And if there's no xanthochromia, you've got it's helpful. If you wait till the lab gets around to doing it, and the red cells start lysing because they're in a low protein environment, right? Even an elevated protein in the CSF is relatively low. You're going to see xanthochromia reported that may not have been present at the time of the tap, but for some reason they don't have those available. But they were very handy, very quick to do. It takes a minute or two to spin it down.
She also had her MRIs done, and so we can see here that she has, again, long segment involvement of her left optic nerve. Any comments on that? Then the other thing, if we recall, she had a clear spine MRI back in 2009, and we didn't present more recent MRIs before 2020, but those had been, her spine had been clean of lesions until now. And so here she has, these are T1 post-contrast images, and so she has multiple lesions there, which are new.
I think Dr. Froman has his hand raised. If you're talking, Elliot, we can't hear you. You might be on mute. Maybe you accidentally pushed the hand signal. So why don't you continue going, and then we'll see.
So here are the MRI results, and then what I want to point out is that she was found to have left supraclavicular, mediastinal, and extensive retroperitoneal lymphadenopathy. She had a CT, chest, abdomen, and pelvis. Again, that extensive lymphadenopathy was seen, and then there was a suspicion for hematologic malignancy such as lymphoma. And if we recall, we have a PET scan from about 10 years prior, but this, and then she as I said, she had MRIs after her initial presentation for follow-up, and there was no lymphadenopathy then. And so we had also that 25-pound weight loss that she reported for the prior 3 months. So she had an SPEP, which showed hypogammaglobulinemia and a spike in the alpha-2 region. Her CSF flow cytometry was abnormal, showed 50% phenotypically abnormal cells of monoclonal kappa positive B cell, phenotype with CD5 19 predominance and absence of CD20. She's on Rituxan, so that was thought to be the reason for that. And so it was felt like that flow cytometry pattern could be consistent with CLL or SLL, but she did have a biopsy, and we're going to go through that. And so I'm just showing here her CBC with differential. So her white count was 11.9, which, if we recall, had remained consistently elevated. And so it was neutrophil predominant, or at least that's what was consistently seen in her CBCs. So in terms of going back
Can I ask you one quick question? I know we're running late, but did somebody do immunofixation on that?
I would need to go back and check.
I believe so. I don't remember the results.
I think so too, but
yeah.
Because a very slow gamma can migrate in the alpha-2 region.
okay. Going back to her optic neuritis presentation, or what brought her into the hospital. So she did not improve after receiving 5 days of IV steroids. So she got Plex. Then she was started on prednisone 60 milligrams. And she was seen by hematology. She was diagnosed with indolent lymphoma, CLL versus SLL. She had a left supraclavicular lymph node biopsy, and then a B-cell lymphoma was confirmed. It was recommended by hematology to start acalabrutinib, which is, for those who are not familiar with this medication, is a second-generation BTK inhibitor. Most of the clinical trials for the treatment of CLL in older individuals were done with ibrutinib, which is the first-generation one, but this acalabrutinib is supposed to have less side effects since it's supposed to be more specific, and is not supposed to. So essentially, conclusions were drawn from the ibrutinib trials to the use of acalabrutinib, and then there's also been trials with concurrent use of BTK inhibitors with anti-CD20 agents for the use for the treatment of CLL in older individuals, and it has not been seen that there is a benefit with the addition of anti-CD20 therapies to BTK inhibitors. Just wanted to throw that in there. Upon discharge,
for those of you that may not know, BTK inhibitors are being tested in multiple sclerosis, and in part, the mechanism of action is actually quite unique, where it seems to impact both the adaptive and innate immune system, which, for the therapies that we have currently, the majority, we could say, don't really have a direct impact on the innate immune system, meaning microglia, macrophages, et cetera. So it's an interesting class of medications that could be useful for some of our patients. We'll have to see, the phase 3 trials that are ongoing. But there also is interest in maybe combination therapies, whether that'll occur from a risk safety profile, I'm not sure. But it is a very interesting class of medications for a lot of our patients.
I will briefly mention that trial. I'm almost done, so I know we're short on time. And I just wanted to point out that she did not improve much after receiving plasma exchange. She has no light perception on that right eye, and her left eye is 20/200. So there's many points of discussion. Just wanted to, before we go there, I just wanted to point out this is a trial that Dr. Newsom was referring to, and ibrutinib was tested against placebo. There were 5 groups, several doses of ibrutinib, 25 milligrams daily, 75 milligrams daily, and 75 BID. Dimethyl fumarate was also tested, and so this was a phase 2 trial that essentially met primary endpoint, which was total number of lesions at weeks 12 through 24, but it did not meet the secondary endpoints, which were progression and then reduction in annualized relapse rate. So yeah, we'll have to see. So those did not reach statistical significance. So rituximab and the risk of second primary malignancies in patients with non-Hodgkin lymphoma were assessed in a systematic review, and it was not seen that those who had been treated with rituximab after pulling all these studies were at higher risk for having secondary of having malignancies from the treatment with rituximab. And then, so this is what I was mentioning before. There's several phase 3 trials that have been done testing the use of both BTK inhibitors and anti-CD20 agents to treat CLL in older individuals, and there's no added benefit of using both agents. In younger individuals, what is used to treat CLL is rituximab or other anti-CD20 agents with chlorambucil. But essentially, the benefit of using a BTK inhibitor that is thought to be less toxic for older individuals. This is kind of what kind of the incentive for using these medications. And the patient's hematologist is okay with us administering rituximab if it is required for the further treatment of her condition. So that is part of the discussion if we feel like she needs to continue on Rituxan or if she failed Rituxan, but these seem to be safe to administer together. And I think there's just information needed for the discussion.
And maybe just in interest of time, I see Dr. Fox, Dr. Goodman are on the call. I don't know if you have any final thoughts about this in terms of would people pursue continuing rituximab given that she was stable for so many years? And, putting aside what hematology had mentioned, it's safe to do, or are there concerns that rituximab may have, put this individual at risk to developing a malignancy down the road, which there's some data, if you immunosuppress patients long enough, that opens the door for malignancy. So any thoughts? And I guess one other thing, should never ask too many questions, is do we feel comfortable with the NMOSD diagnosis? Or do we feel this is something else? And Jen shook her head no.
Yeah, she's been seronegative for aquaporin for MOG. I know that this has been an indolent course, but do we not think that this is all one unifying diagnosis? CLL goes everywhere. I don't know, the nerve that's dead, I was going to ask, I guess if we had thought, in hindsight, always 20/20, but when you have a dead nerve, you can consider biopsying the perineural sheath, or, you could try to establish that. For the good nerve, you wouldn't want to do that. But to me, this might be all a unifying diagnosis. I don't know what you pointed out, Dr. Fox and Dr. Goodman, as well as Balser, Galetta, Froman. Others want to weigh in?
So, this is Andrew. I'm with you, Jen. I'm not sure what was being treated all along, but this probably puts it all together. I think should be treated by the hematologist, frankly. And it would be great if, as you said, if you could confirm something with a biopsy. But I think lymphoma can be incredibly indolent, and I've remember a case from residency 40 years ago that had been going on for 15 years in the ponds, and just fooled everybody for a decade and a half. You can't put lymphoma aside just because it took so long. I just think it's just a very rare, difficult case, and I certainly don't second guess what was done. It's just I think it's just important to remember that we deal with uncertainty, and we do our best.
No, I think that those are great points, and I think what we have learned, or at least I've learned, it's always good to go back to the drawing board, and when you have features that take a different route, when she developed systemic symptoms, obviously we were very concerned. She developed that leukocytosis. Clearly there was something else behind the scenes that was occurring, whether this is a one unifying diagnosis, or is this sort of a what do they say, thick of thieves in the night, two processes in parallel working together. I'm still not sure myself, but what do others think? Because again, we're sort of at this crossroad. Do we continue Rituxan with the BTK inhibitor? Do we just say let's go BTK inhibitor with the hematologist?
Oh yeah, go ahead.
Can you hear me now?
Yes, we can hear you
now. Oh,
Finally.
good.
Jen, by the way, muted you on purpose. I think that's what happened.
What?
Okay. That's good. Yeah, that's okay. But I agree. But I agree with Jen. I actually agree with Jen here, and the head shaking. And I think, unlike cases we've had previously, which have been fabulous presentations, that really Hickham's dictum, right? The patient can have as many diagnoses as they damn well please. And this was Nita's paper that was accepted. One of the fellows that presented, it's now in press. And there were multiple diagnoses. NMO, we had, an occult ovarian tumor, thyroiditis, we had anti-NMDA, anti-AMPA, crazy stuff, but we kept going. I think this particular story, that nerve, the dead nerve, which can be biopsied, doesn't preclude or militate against things. But if you had that biopsy that demonstrated the pathology about on a hematologic basis, I completely agree that, we'll follow this patient, but I think hematology would need to pick this up, because where else we got to do a staging, all kinds of things come to mind. So I think this is the place to go. But Danielle addition, and that is her vision is lousy. The question I want to ask you is, have you tried 4-aminopyridine, Ampura or the generic potassium channel blocker, just because there may be fibers that are segmentally demyelinated but not dead, not necessarily transected. And the question is, can you drive some current through those nerves? And so from the symptomatic point of view, these are patients which I've had over the years that can't see. Guy was on his farm, I'm here in Texas. He has a tractor, he can't do it. I put him on 4-AP. All of a sudden, he sees shadows and buildings, and he's cutting the entire property like he did before. Bad vision, but he didn't run into anything. We had to make sure of that. But thinking about this from the patient's perspective, this is a monumental loss of function, and we've got more angst coming. But it might be worth trying 4-AP for this patient. There may be other things.
Love it. I love the idea. I think
Does that stuff
we
really
focus
work?
on the immune therapies all the time, and we perseverate on what is best for the person. But we have to also think about the quality of life, which I think is what you're bringing up, which is brilliant. So we have not as of yet.
Okay.
So Scott here, can I just make a comment? The patient was stable on Rituxan for quite a while. It's approved in 1997 for B-cell lymphoma. It can be used in CLL. I would think the hematologist would have to weigh in and say, wow, maybe she has some mutation. Maybe it's resistant. Maybe we should look at CD19 or another CD20 or something besides the Ritux. That still might work.
How about blocking antibodies? I mean, the hematologists, when that was the only anti-CD20 out there, when patients would start to break through with lymphomas that had CD20 on them, you still can check for blocking. Remember, it's not a totally humanized antibody. So I would love to know what's sitting in her sinus, is both of them.
Thank you.
Well, that was
So why don't we move on to the next case?
Yeah,
Yeah,
fantastic
no,
case. Great job. Really great points. All right, Dr. Goldschmidt, I think you're up from Cleveland Clinic.
Yep, let me see if my share screen works now.
So while we're switching, my original training from Texas and Penn in neurology and MS was when you're getting those first taps and people you suspect have MS, but there's anything weird about how they're presenting with MS or NMO, just go ahead and get the cytology while you're in there. Not that it would have shown up the first time in this patient, but I was trained that way, and I still think that way, which is if you're in there and they don't like getting their spinal tap done, at least think about the cytology early on. That was my original training, and just maybe another pearl to take away from this for the fellows. If you're not sure, get the cytology.
Galetta will tell you that that started at Penn even before you were there. All of my patients who get tapped get cytology, not necessarily flow, but certainly get cytology. Atypical lymphs, you never know.
All right, how are we doing? Are you able to share screen?
No, I've been having trouble for the first time today ever sharing my screen. Let me.
Well, just let me.
Carolyn.
Yeah.
On my end, I had a problem earlier today because Windows Firewall has started blocking it. I don't know if you're on a Mac or Windows device, but my firewall newly started blocking Microsoft. I don't know if you can disable yours for this.
Let me double check. I'm on a Mac, but it does say I have to do something.
And Carolyn, if you can't share, I have the slides up so I can certainly present for you.
Thank you.
Would you like me to just go ahead and do that for you?
Yeah,
okay.
Thank you. Sorry. Of course, this is the first time I've ever had trouble sharing my screen.
No worries.
that Murphy's Law, right?
Okay, can we see my screen?
Yes.
There it
Yes.
is.
Yep.
Thank you so much.
You're welcome.
Very good. Okay.
Okay, so hello, I'm Carolyn Goldschmidt. I'm a neuroimmunology second-year fellow here at Cleveland Clinic Mellon Center. I'm presenting this interesting case today for you all. So this is a 57-year-old female who has actually been following at our clinic at the Mellon Center for a number of years. So she was originally diagnosed with multiple sclerosis in 1983 when she was about 19 years old, 19, 20 years old, symptom onset a few years before that. And from what I can tell, she initially presented with numbness in her bilateral lower extremities, which progressed to weakness. She was diagnosed with transverse myelitis, and she recovered fully over the course of several months. She then developed some diplopia and dysarthria, and then at that point, the diagnosis of MS was made. And the first note that I could see in our electronic medical record system was in 2006, and that note said that on average she had about 5 years of symptom-free periods between attacks, and 2 years ago she had an episode of total body weakness and tightness that resolved except for left leg weakness. So about 2004 seems like was her last attack. Next slide, please. Oh, can you go to the next slide? Okay, perfect. So this is her history of the medication she was on for her MS. So she was started on Avonex, right around when it came out, was on that for a few years. And then due to side effects, she was switched to Copaxone. And she was on that for actually 10 years before I saw her. She was switched to the 40 milligram dose in 2014. And then in February 2019, because of insurance issues, she was changed to Glatopa. And then at that time, she reportedly had a relapse. She was given IV steroids for this, and it was labeled deafferentiation syndrome in her left upper extremity. And she said that it started 6 hours after that first injection of Glatopa, where she had pain and weakness, and basically described ataxia in the left upper extremity. And then she afterwards actually developed some balance issues and confusion, which improved over time. So because of this, she was switched from Glatopa to Glatiramer after taking a few months off. She's also been following with the spasticity clinic for many years, getting regular Botox injections for her left lower extremity spasticity.
Time out quickly, go back. She went Glatopa to Glatimer.
Yes.
They're all Glatimer. What did you mean?
She went to the generic.
Okay. Another one. Thanks.
She just kept switching around between the different brands.
Okay.
Okay. So after that event that she had a brain MRI, and that showed greater than 3 new lesions with no enhancing lesions, and that was compared to a couple years before that. Her exam reportedly at that visit was stable at the time, though her processing speed test did decrease. The manual dexterity time in the left hand was about the same, but the right hand actually got faster, though her time 20-foot walk got a little bit slower, and she reported some increased daytime fatigue. So at that visit, the discussion was kind of started about changing her medication to Tecfidera because of the lesions seen on the MRI scan. And then next, we'll show you her initial imaging, or the initial imaging that I will present to you. So this was in May 2019. That was done at that time, showing 3 new lesions. She, before this, didn't have any spinal cord imaging, but this was her imaging, kind of showing, the typical MS lesions, perpendicular to the ventricles, with a little bit of hyperintensity in the brainstem. You can see there as well. Next slide. So in November 2019, a few months after that relapse in May, she called in stating she had bilateral lower extremity weakness and initially was unable to ambulate at all. Her husband had to carry her to the bathroom. Her primary care doc started her on like a prednisone course, They also found a UTI, and she was given antibiotics for that. And then she improved over the course of a few weeks to be able to walk with a walker at that time. Next slide. So I first saw her right after this. She was kind of an urgent visit. I saw her in clinic for the first time, and she said she really just hadn't felt well since switching to the generic glatiramer. Even though, she was on Copaxone and Glota, they're all glatiramer, but since switching to this one, she just said she didn't feel as well. My first neuro exam with her, she had full strength in her upper extremities, a little bit of weakness in the right lower extremity, and a decent amount of weakness in the left lower extremity. Some, sensory changes in the left greater than right lower extremity. She was brisk with no clonus. She was a little ataxic in the upper extremities. And when I first saw her, she was in a wheelchair with a very unsteady gait. And at that time, because she hadn't had one before, we did an OCT that had normal retinal nerve fiber layer thickness. And we talked more about switching DMTs at that time and decided switching to an S1P receptor modulator. And Siponimod was kind of the one that was out at the time that we decided to switch her to. Next slide. So at this point, just take a break if anybody has any thoughts, or this seems kind of a pretty straightforward case so far.
Did you say that she was on Tecfidera before?
No,
the S1?
they
Or-
talked about switching to
They
it, but she
talked.
never actually switched.
Oh, okay, thanks very much.
Yeah.
Great.
So we can start with the fellows and then the faculty, but I think some of the more interesting slides are still coming. So, but does anybody have any concerns about her diagnosis, or how they're trying to improve her treatment plan? Anybody disagree with the diagnosis or treatment plan? Any other comments about the case? Okay, Carolyn, I think you can take us into the next part of the story.
Thank you. So after there was a few delays getting the startup of Siponimod started, but she was started in February 2020, and then a month later, she called in with difficulty walking, whole body weakness, dizziness, dysarthria. She was given high dose steroids for this. And then the symptoms really kind of continued throughout the next month, and she developed some confusion, worsening spasticity, worsening numbness. And she was also treated for UTI at this time. And this is kind of a pattern over and over where she has recurrent UTIs as well. So next slide. So at this point, we got imaging after this, and here you can see it showed multiple enhancing lesions. Okay, so at this point, that was me. I panicked. It's like, why does this lady who's been so stable for many years have these multiple enhancing lesions? Next slide. So I saw her again after this. She said that she actually, at this time when she just had this MRI, she felt a little bit better. She did some physical therapy. Her left hand was a little bit better. She was again able to walk with a walker. She has some help at home while her husband's at work. She had some mood issues, so we started on medication for that. She's on other symptomatic medications as well. My exam this time showed new left upper extremity weakness, worse distally than proximally, new clonus, and worsening in coordination left hand. But because of the multiple enhancing lesions on MRI scan, we gave her 5 days of high dose steroids and plan to switch her to ocrelizumab to escalate her treatment. So we had, again, a delay with the Ocrevus. Her ALC was actually pretty low, 0.2. So we paused the Siponimod. She also, had to get some other blood work done. So in the meantime, in June, her husband called stating that they found her super confused, disoriented. She was unable to walk. So, I recommended that they go to the ER because of this. She then had another brain MRI scan there. There was no enhancement or evidence of ischemia or stroke or anything else going on. At this time, she also had a MRI of her cervical and thoracic spine that showed lesions that had been there, but they were non-enhancing. She was again given antibiotics for UTI as well as high-dose steroids, and eventually was discharged home. So then, just a week after that, she was readmitted to the hospital because of worsening gait and also other symptoms like dysphagia, weakness. And then shortly thereafter, she was actually transferred to the ICU for presumed sepsis, though they never found a source, but she was hypothermic, hypotensive, difficulty to arouse. She actually required intubation, pressors. She was treated with antibiotics. They repeated imaging again without any evidence of enhancement. She had a lumbar puncture at that time that showed, not very many cells, relatively normal protein, glucose, mildly elevated IgG index. She did have positive oligoclonal bands, both in the CSF and the serum, but greater in the CSF. And then infectious workup was negative, including JC virus in the CSF. They also put her on continuous EEG monitoring that was negative for any epileptic activity. And then she just improved slowly, was eventually extubated and discharged to acute rehab, basically back to her baseline strength.
It's Bob Lisek. I have a question.
Yeah.
So there are more bands in the CSF than the serum. But how many bands I like the raw counts. How many bands were in the serum?
Oh, I don't know. I'm not sure.
Because I
don't think they didn't document it. They just said more in the CSF than the serum.
Okay, well, I mean that's a problem in a lot of reports, frankly. I mean, if you had 5 extra bands in the CSF and you had 6 in the serum and 11 in the CSF, their MS patients don't have 5 bands in their serum.
Right.
Okay, how many do they have in their spinal fluid?
Well, what has caught my attention, and I don't know if other people on the line, especially the fellows, is how this person went from, a modest disability to like really severe disability, regardless of the therapeutics that the person's on. If you just, ignore for a minute the disease modifying therapies, I mean, this is highly unusual, at least in my view. Even someone who has longstanding MS to have this precipitous decline like this, for me, it raises huge red flags. And I think it's, part of these webinars is really to sort of think outside the box, even if something is cookie cutter from the start, but you always need to consider other etiologies and whether it's something completely different or, as we saw with the other case, or at least what I feel is 2 complete different parallel disorders that are causing the disability. So I don't know if others have comments about that, but this is like really striking.
Yes, it was very scary.
Yeah.
Really, really great point. And how old is she at this point that she's developing these enhancing lesions and this disability?
57, she was 57.
Yeah, so after, 10 to 20 years without much enhancement and precipitous change, I agree with Scott. It's pretty dramatic.
Yeah.
And I may have missed this. I'm sorry. I had to step away for a minute. Is she Caucasian? Is she Black? Hispanic? Oh, okay.
Yeah. Would this not be, I don't want to say typical, but when we think about secondary progressive MS, is that not a common trend that we see, though, where someone is stable for many, many years, even 10 to 20, and then they start their progression usually in their 50s, and that's when they really sort of take off?
Right, but she was still so inflammatory with all those enhancing lesions in her brain.
In fact, she's acting like she's going back to her relapsing phase.
Yeah, that's right. Secondary progressive is, you're making a great point in terms of temporal relationship. The problem is this is moving at an accelerated pace, right, in conjunction with evidence of ongoing inflammation, breach in barrier integrity. This looks like she's returning to a really fulminant inflammatory phase, and it's accelerating her progression. It looks like that, I agree, but this is much faster. This should really,
that's why Fred Loveland likes to insist, and he's right, that we don't use that term. She's accelerating her disability.
I do want to mention, though, I think it is a
progression.
great point that you bring up. I think that was Sarah, is that, it's falling off the cliff phenomenon, meaning that, after a certain age for a lot of our patients, their neurological reserve is not as robust. And so the compensatory mechanisms are not there. And so it seems like those patients that sort of transition to SPMS, it happens quickly, but it not like this. I mean, this is like, overnight, someone goes from, speaking to intubated. It's a bit different. And you, Carolyn, you'd mentioned there wasn't a presence of infection.
Right.
Is that right? So that's
there was no clear infection. They treated her for sepsis, and she kind of always had a UTI, but there was no good source at this time.
I have a quick question. I know it might be a little bit soon, but I think you also mentioned that the fingolimod was stopped in June. So is there possibly a component of rebound? I know she already had some
I'll
breakthrough before.
Get into that. But yes, this was one of my concerns.
Gotcha. Okay, thanks.
Yeah.
Carolyn, I was going to follow on that. I was actually wondering, you mentioned her ALC count was 0.2. And I was wondering if it was still low in July or if it had come up yet, but you're probably going to talk about that too.
I actually don't remember what her ALC count was when she was in the hospital. It was up. We basically just want to see it to go up a little bit before starting Ocrevus. But at this point too, she, had recently gotten steroids and was probably infected. So I think her ALC was kind of like falsely normal at this time.
And we have an expert about sort of the fingolimod rebound on the line. Dr. Graves, you had published one of the original, I think, case reports or case series, and obviously this is a different S1P receptor modulator. However, there are concerns with, I think, the modulators that have even a shorter half-life, that maybe there's even an accelerated, more robust rebound than what we see with fingolimod. So I don't know, Jen, if you have any comments on that based on the temporal course.
Yeah, I mean, we have no reason to think the other ones are going to be less likely to cause the rebound. We just have less data so far, and I think we're all watching out for it. So hopefully there'll be fewer cases to report of rebound in the newer S1P drugs. But yeah, as I think we might have reviewed in another one of these sessions, it's about, most studies are landing at about a 10% overall chance of having this rebound if you're taken off an S1P and not placed fairly quickly. The time frame of the rebound seems to be, for most of the cases that have been reported, somewhere between 6 weeks to 3 or 4 months after cessation. And sometimes if there is delay, even in starting a B-cell depleting agent, there still may be risk if you don't get that on board or another therapy on board within 3 to 4 weeks. There's some risk. So certainly could be something to consider. Most of the individuals that have had the rebound have been a little bit younger, maybe, than this patient. The most common scenario is often women who have stopped it because of teratogenicity concerns and trying pregnancy, and they tend to be a little younger than this patient, but still a possibility. So let's see what happens next, Carolyn.
Yeah.
So
Jen,
it's Scott
Jen,
here.
what
Can I
about-
just
Scott,
add into that? On the S1Ps, just so you know, the PD on the different ones is distinctly different. So that with fingolimod has the longest effect, that takes 2 months before you see lymphocytes returning to baseline.
Yeah.
Ozanimod, which we published on, which I did with whatever it is, Celgene, whatever they became, published the data that we had in N2 was from my lab looking at lymphocytes. It's a softer, gentler one, and it will recover more quickly. Siponimod is probably somewhere in between. So in terms of rebound, if you have an acute, reconstitution, like we're thinking of, like with the Tysabri, that's when you're going to be predisposed in that window. So I would think that the prediction would be with the Ozanimod being a softer, gentler, may not have as much of rebound, hopefully. So I'm going to add one quick point.
Prophylactic.
And Bob, you're on. Not helpful comment here is somebody made a goof by taking her off and putting her on a generic GA. Let's not forget that GA she was stable on for how many years, and Copaxone is GA, and you've got how many different forms of GA, and they're not exactly the same, even though they have the same 4 amino acids, YEAK. Doesn't account for all the enhancing lesions, but I can tell you from my experience, having worked with that drug a lot and published on that and worked on it, just like when I've taken people off this in their 60s who've been stable for 15 years, in their 60s get GAD enhancing lesions.
Yeah,
which shocks the heck out of me.
yeah,
No,
the
I think
other
that's a
thing
great,
that's not
great
flying
point. I think
is
that's
that
a
if you
really
do-
great point. So I suspect Carolyn will tell us that that was an insurance-driven
That was an insurance.
decision going from the sort of the brand to generic. And I've had the same experience. The generics, for me, have just not worked as well. Like we've had breakthrough disease activity in the same exact situation. Someone
I mean,
stayed for decades.
You can't really prove it, but
disease reactivation.
we can't
What
prove
is
it. I mean, you're probably
tolerogenic
right.
becomes immunogenic. And it's very easy to switch. And even if the composition is close based on the molar ratio between YEAK, GLAT, GLAT, you still have differences. And if the formulation can turn something in regulatory that's more immunogenic, it doesn't account for the GAD enhancement that she had after the S1Ps, but it certainly crossed my mind with my Teva marketing hat.
Well, there
Yeah.
there are studies showing that at least in vitro, that they don't do the same gene enhancement. So there are differences at least in vitro, and who knows about in patients.
So I think
You're right. Thank you, Michael.
I think there's one hand up. Sorry, Scott, I didn't mean to cut you off. If you had more there.
No.
So
No, thank
I think there's one hand up. I think it's Dr. Froman, and then Carolyn's only about halfway through her slides. So I think she's got some more key pieces of information to go here. So Dr. Froman, did you want to say something, and then we'll let her try to get through the next few?
Sure, just two things very quickly. One is we didn't hear anything about steroid bridging in the transition from the S1P to another agent. So we may want to comment about that. The second one, I'd like Scott Zamville to comment, and that is in the different GA preparations. We know years ago, Nitin Karandikar demonstrated that over about 4 to 6 months, you would see with flow this expansion in the CD8 cells, which are very surprising. Back then, these were CD8 regulatory cells. There was this idea that it was linked with efficacy, and those patients who don't respond to GA seem to not go through that transitional switch to demonstrating that escalation of the CD8 regulatory cell, which was published in JCI, and David Hafler had a nice editorial about that. So those are the two things. One thing is steroid bridging, and the second is, Scott, are there differences in the CD8 regulatory cells across these different versions of GA, or would that be a fruitful laboratory exercise to demonstrate?
Probably not terribly productive, but it's a great 2002 JCI paper. One of the most beautiful papers on GA.
I believe that
great.
was
Now
total CD8, so we don't know what subsets were involved, Elliot.
Yeah.
And
Time to
steroid
move on here again. Great. Yeah.
Okay, Dr. Goldschmidt, let's see what the next twist was.
Oh, so this was me panicking again. But she was actually discharged to acute inpatient rehab after that. And then within a few days, I got called from her rehab facility saying that she, over the course of a couple days, developed quadriparesis, basically. And she was only able to move a little bit of her hands and her shoulders and her toes. And she was given steroids. So on the left here, you can see her MRI scan from when she was in the hospital that showed non-enhancing spinal cord lesions that were discontinuous throughout her cervical and thoracic spine. And then in rehab, this was her imaging after she developed this quadriparesis. So you can see this massive lesion in her cervical spine that was swollen and enhancing and just horrible to see. So again, this was, and she did get some steroids, like Dr. Froman was talking about. She got 5 days of high dose steroids at the end of May due to the MRI with enhancing lesions. And then she got steroids again when she came to the hospital at the end of June. And then I believe she also got steroids during that admission in July. And then after this, she also got steroids as well. Okay.
So can I just make a comment?
Yeah.
That longitudinally extensive nasty lesion, in my view, is not MS.
Right.
I don't know what it is.
We'll get there.
I agree.
Yeah, but that when you see that, regardless of where the person is in the course of their journey with whatever neurological condition they have, you see that. I mean, I would venture, I'd put my house on that it's not MS. If it's a true longitudinally extensive lesion, right? You can have patchy lesions that coalesce. That's where the axial cuts help supplement the sagittal cuts, but that is concerning.
Right.
That much swelling also, Scott. You just don't see that.
Yeah. Another way of saying that, Scott, is that it's a new kind of MS. This is what I like to say. It's called not MS.
There you go.
Yes. So I freaked out. I thought that I gave her rebound activity from the stopping the Cipanimod, and I was panicking during this time. So you can go to the next slide. So after this, I directly admitted her to the main campus for plasmapheresis and some more steroids. And then, we had them check aquaporin 4 and MOG antibodies prior to receiving any Plex. This, of course, hospitalization was also complicated by encephalopathy. She actually developed acute depression and suicidal ideation because she was unable to basically move at all. By the time she was discharged, she still really had minimal movement. So she could kind of shrug her shoulders, wiggle her fingers a tiny bit, and wiggle her toes a little bit. Her reflexes were down. She basically had no feeling throughout. And she ended up being discharged to a SNF after this. This doesn't have anything to do with her neurologic case, but just a social point. The SNF actually ended up discharging her on hospice because they told her she was an acute renal failure and she was dying, even though she has no history of renal disease. And it ended up that she had a kinked Foley that her niece found, who was a nurse, when she came over to her house to say goodbye because they thought she was dying. Yeah.
My God.
Yeah, it was horrible, and I didn't hear about this, and for a while, actually, it was a mess. The husband really didn't want to pursue legal action, even though we encouraged him to. But I mean, she was fully discharged home on hospice and told that she had a few days to live, when really it was just a Foley catheter that was kinked, and she didn't have urine output because of that.
Oh my God.
Yeah. So just a side note.
Carolyn, you kept seeing her. You were doing great. You kept, every time I saw you readmitting and examining, I said, yes. But then,
I know, and we actually heard about this from the Genentech rep who reached out about her Ocrevus, and the family described this, so that I found out because it was just like a tragic mess. And of course, it's the nicest family in the world, and she is super nice, and her husband is lovely, but they also live in the middle of nowhere, Ohio, and have difficulty getting to some of these facilities.
Dr. Goldschmidt, before we go to the next slide, because I think maybe we get an answer either on the next slide or the one after, but do you want to take a poll? What do we think this patient has?
Yeah, let's take a poll.
Maybe start with the fellows first.
Yep.
I was gonna say it kind of looked like in the imaging, like a trident sign, which I know you can see in sarcoid. But I want to say I feel like it's also been described in other inflammatory myelopathies as well. But NMO spectrum disorder, given it was like an S1P modulator, could be considered, since that can worsen NMO spectrum disorders as well.
Great ideas. Other fellows, do you agree? Any other thoughts what this is going to be?
How about voting for both?
That's called a case report.
Well, I sent Scott a similar case. Unfortunately, it's screenshots with my camera, but I have a similar case, and I know Weinshanker has a few, because when I showed him the pictures one time at the academy, he says, yeah, Claudia said you were going to come and show those to me. He says, I got a few like that also. If you can have myasthenics have 10-15% of them have thyroid. Why can't you have 2 autoimmune diseases? Why not? People do.
Okay, any other comments before she takes us through what they discovered? All right, go ahead.
Okay, thank you. We can continue. So after this, her I'll go back one slide. Sorry, her aquaporin 4 came back positive at a high titer, 1 to 2560. Okay, so continue.
Right, this was serum, not CSF.
That was serum. Exactly. So this is just a timeline of her case. So, it's not to scale per se, but it's a nice illustration how for 30 years she was pretty stable with her MS and had a pretty typical MS course. And then it wasn't until February 2019 that she kind of started to have all this increased activity. But, initially it still just looked like inflammatory MS again with those enhancing brain lesions. And then you can see how, she was switched from an interferon and then, went through all these, Copaxone to Glatopa to glatiramer kind of arbitrary changes. And then the S1P, but kind of, kept having these relapses. So the red lines are relapses and the yellow arrows are when she was given steroids during the time. And then her Ocrevus was actually already approved when she was in the hospital. So we ended up just proceeding with the Ocrevus to treat her aquaporin 4 positive neuromyelitis optica. So she got her first doses in November 2020, and she's continuing, but she still is very disabled from that.
And the diagnosis you put down for Ocrevus, though, is MS?
Yeah, I put MS.
Good girl. Good girl.
Otherwise, you use
We're very proud of you.
Uplizna, Inebilizumab.
Yeah, that wasn't approved yet or wasn't out yet by the time when we did this. And, I was just like, I just wanted to get her on something fast, and this one was ready to go.
So I have a question for Scott Zamble about this, because I know there's a scant literature out there with Copaxone and its efficacy on NMO. Or maybe I'm just making this up and I'm going with Mike Levy, what he's told me. But I feel like NMO at some level, maybe this case report level stuff, but Copaxone and how it works maybe could contain NMO at some level. I mean, there's no clinical trials showing that, but it just is curious that she went so long with disease that's controlled. It just, and then she switched to generic and things just got very unwieldy.
And she was on an interferon for so long, which, has reported to
Sure.
worse.
Yeah, actually can unmask and worsen.
Right.
Well, the
So,
interferon,
Tysabri, S1Ps, we all know make NMO worse. Enough case series and reports that we accept that.
the Japanese
Copaxone makes bad. And to me, with Copaxone, it's a water pistol for NMO. But on the other hand, I think the whole mistake here was that they left that good old Copaxone, and the insurance company caused the whole problem. I'm sorry, I'm just kidding.
Yeah, no, I'll blame insurance.
Thank you. I'm glad there's another Bernie Sanders fan on. By the way, the original opticospinal MS in Japan got worse on interferons. We now know that about 95% of them, if not more, were actually NMOSD. But that didn't bring it out way back then. So, I mean, you can have two autoimmune diseases. Again, my patient was NMO aquaporin 4 negative. When I tested her, she had them almost simultaneously, the diseases. And then when the newer assay came out, I sent another specimen, and guess what? Positive. So,
Dr. Goodman looks like he has his hand raised too. Dr. Goodman, did you want to weigh in also?
Yeah, just a quick comment. I certainly agree with Bob's assessment that you can have lice and fleas, so to speak, and I think that's what was going on with her. What provoked it? Was it switching? I would say playing yo-yo with the immune system can result in bad things. But my question for everybody is: does anybody have any experience with these very aggressive longitudinal myelitis cases of using the satralizumab acutely to try and quiet things down? Does anybody have any experience whether that's a good idea?
I guess what I don't know, and others may know, is what is the penetration to the CNS? I mean, we've often used in the acute setting high-dose cyclophosphamide because it penetrates the blood-brain barrier beautifully, and then transition them over to B-cell depleting therapy as one choice. I just don't know in acute relapses.
I treated my patient with a cyclophosphamide, and as an aquaporin 4 negative when she had a horrible attack because
Yeah.
I thought I was treating the way Howard Weiner reported, Omar and I reported, and then Jeff Cohn about using cyclophosphamide in those days before Tisabri for totally out of control MS. Yeah, I mean.
So I agree, and I mean I ignorantly did the same thing decades ago, thinking when we saw these cases it was really bad MS, and we used Brigham style Cytoxan. So sure, but I'm asking specifically about the
Satralizumab.
Yeah, the anti-IL-6 receptor approach. Does anybody have any experience with it?
Yes, not enough experience, but even if you look at the data and you don't have the head-to-head, the onset of activity is felt to be a little bit slower.
Yeah.
I look at eculizumab as being in the Tysabri of NMO. If I need something fast and quick, I believe the eculizumab and the complement inhibition would be the fastest acting. But that's not data driven. It's just
I understand.
trials.
I understand, but that's what I'm asking.
Reported an IL-6 inhibition in somebody who kept breaking through. That was one of the first cases, but again, that's a case, as Scott said, not a big series.
Yeah, and I would say if this is a person that's inpatient going down the tubes, Cytoxan is easy to get compared to the newer therapy. So we will just blast them with at least one round of a Cytoxan while we're waiting to get one of the FDA-approved therapies. And then if there's a delay, hit them with another round of Cytoxan. And I'm sure Elliot probably will relay maybe the methotrexate leucovorin rescue. I have not done that.
That was exactly my point, and we've published that, and we've continued to use that in patients that we consider to have fulminant inflammatory brain, spinal cord, or both. And let me just say that some of that was on the heels of Cytoxan failures, because I'm a big Cytoxan fan as well. But we've had patients who have continued to basically spank us and continue to have progressive inflammatory and vasogenic changes in brain and spinal cord where high-dose IV methotrexate with leucovorin rescue, the protocol is published and also published for severe COVID-19 last year. So Hope, I will send you a couple of papers, the original fulminant cases that were treated with methotrexate and leucovorin rescue. I'm not the only one. I know Ben Greenberg does a lot of it. A lot of my colleagues now around the country have done it. Similar kind of outcome. And that's given every other month. And then, like you would have said, Scott, then you would transition to some other main stem therapy. But I'll send you that, and then also the protocol paper, part 2 of the 2-part COVID-19 series.
Excellent. And, Elliot, I saw your hand was up. Was it for that point, or did you have another one?
No, that's it. Thank you. That was exactly it. He read my mind.
Okay, good. So I know we're up against time a little bit, and Carolyn has a few more slides, but I am curious to know how many people think this has been NMO all along, or if these are, as has been said, ticks and fleas, and what we thought about the early MRIs in this case, and if there was anything inconsistent with MS in the early MRIs. And maybe Dr. Goldschmidt, you also want to comment on, now looking back, do you think this was NMO all along? Do you think this is, immunosenescence in the 50s and plus maybe fingolimod, and we see maybe a second peak? I don't know, Scott, if you agree with me that there's a little bit of a second peak of NMO, just like there is with rheumatoid arthritis, as women become postmenopausal. So I don't know if we think it's that combined with fingolimod unmasked a second problem, or if you think it's been NMO all along.
Yeah, I honestly am struggling with that question too. I mean, it seemed so consistent with MS. She had a normal OCT, before all this that we checked before starting the S1P. When she did end up having spinal cord lesion, it was all discontinuous lesions that seemed old. So, I mean, this has always been my question is, did she have MS for 30 years and then develop NMO? Or, was she kind of super duper lucky for 30 years and had NMO that was, inadequately treated, and then developed all this activity. I don't know.
I would say the beauty of this case, though, is you have one drug class that can treat both.
Right. Yes.
Treat both effectively. So regardless of what this is, whether it's an overlapping syndrome, one, masking another, unmasking, whatever it is, I think the choice of therapeutics at this point in time seems really a good one. And I don't know the answer. I think this is a really challenging case, and but Ocrevus or another anti-CD20 or CD19 seems to be a really good choice in this situation. I just want to make one comment, is that don't throw in the towel, because I've had patients with these longitudinally extensive lesions where they've been paraplegic, quadriplegic, quadriparetic, where they can regain a lot of function. It just takes time. She is older, so that has sort of a strike against her, but I think with aggressive rehab, getting her on Ocrevus, treating the symptoms, you may actually improve a lot of her quality of life and function.
Yeah.
So very quickly, can I add in there? We're all taught that the parsimonious approach, we want to make a single unifying diagnosis. However, if there's going to be a case where I have MS and NMO, this is the one I've been staring at the sagittal picture for like 15 minutes, and I keep watching it. It looks more like MS the more I've been looking at it. And if this were my patient and I wanted to give her the best chance, I might try and push that CD19 part of the diagnosis for the only benefit that we know that it hits the plasma cells and plasmablasts. It has a wider breadth, and it might be totally, without data, but maybe more efficacious.
Maybe you could find her some anti-CD38, which will really get the plasmablasts and plasma cells. There are patients in their 70s and 80s who've had NMO, and we thought we had a pretty old one at 79. One of our residents wanted to report a few years ago, and he found somebody older in the literature. So, I mean, it can happen. And just quickly, there was a paper, the Mayo Clinic people doing the assay, and it was from Kaiser Permanente, but in Northern California. And they try to show that it was either or. MS never had this, but there were 2 or 3 patients that that were thought to have MS by the Kaiser neurologist. And they had aquaporin 4, as I recall. So there is a potential for both. I mean, myasthenia and NMO overlap. I've had 2 patients. It's about 11% have the antibody, but about a couple of percent can have both diseases. So why not?
Right.
Why not?
And Dr. Goodman, I'm trying to follow all the hands that are up. Dr. Goodman, did you have an additional comment?
No, only that I'm glad that we finally had an MS case again, at least in part.
A partial MS case.
I'm going to send the picture that I sent Scott Newsom. Carolyn, I'm going to send it to Jeff Cohn, and he can, because I have his email, and he can show it to you. And the sagittal, as Scott was talking about this one, the sagittal of the one I have, Scott, looks like this one. I'm going to send that one to you also. I'll try to send it to a few other people, but Scott Newsom has the set that I sent. They're lousy pictures because they're screenshots, but it's identical. The case could be absolutely.
Do you think this patient's DR2 or DR17? I wonder what the age.
I don't know.
So it looks like we might have 2 fellows with their hands up. Let's see, Jackie and Rosemarie.
Yeah, I just have a question that's in terms of thinking what could be driving the NMO now. Would you consider doing a PET scan to see, just like with her age? I know there could be, like you said, a kind of a bimodal, I guess, epidemiology to NMO, but would you consider doing a PET scan just to see? Because even if it was NMO way back when, I mean, she was really well controlled. So like what could be driving that process now?
Yeah, I'm definitely going to do a malignancy workup now. Logistically, it's been hard just getting her anywhere because now she's basically, she's non-ambulatory, requires stretcher, and they live on like a farm in the middle of Ohio. So getting them in for testing has been hard, but I definitely want to make sure at least she's gets her mammograms and age-appropriate cancer screening, because I know there's been some cases with breast cancer.
I was going to say, if you're going to choose one, modality doing a mammogram, because about a third of the cases end up being breast cancer with the older onset NMOSD. So that definitely is, or maybe even 2/3. I think it might be 2/3 of the cases.
Yeah, I think that'll be the easiest test to get initially as well as the mammogram.
And then, I don't know, Rosemary, you had your hand up, but it went down. So I don't know if it was a...
It was kind of a spin-off of the same thing. Is what age? I'm hearing 50, 55, 60 when they're diagnosed with NMO to actively search for a paraneoplastic cause. And I guess I'm just looking for some opinion since I've heard that wide range.
Well, if the case is presented in this seminar, there's a high chance it's paraneoplastic, but in general, most of them I don't think are, although it makes you wonder how many we should have worked up more closely after you've listened to some of the cases that we've heard this year. I don't think there's a magic number. Unfortunately, aging and cancer risk is not precise, but maybe if you had to think of a number, people over 50 or people with risk factors or people with other symptoms that you worry about. I don't know if anyone has something more wise to say than that.
I would just go ahead and say that with advancing age and immune senescence and the risks, I think we as neuroimmunologists have to recognize that we are inextricably linked to oncology, to infectious disease. I mean, this is one of the most difficult areas of medicine. And I think the idea of searching deeper for concomitant processes that might be a driver or even in parallel, I just think is smart medicine. So really glad to hear about that. And Jack, I want to just say something to Carolyn, and that is, I've had a number of patients that I know by name and face that I followed who had a working diagnosis of MS, oligoclonal bands, high IG index, but be careful, also had the clinical semiology, internuclear ophthalmoparesis, Lhermitte's sign, had bladder dysfunction, Moore's lightning streaks at night, moving their eyes around from ephaptic discharges from their old optic neuritis. And then 6-7 years later, they show up with longitudinally extensive spinal cord lesion. They show up with this scalloped, bizarre lesion in the brain that looks like a cauliflower, and their NMOSD with titers off the charts. And the spinal fluid now doesn't reveal oligoclonal bands. It's almost as if they had MS, may have been burned out or transitioned. I could also imagine that you could see characteristic spinal fluid for MS in a patient who also has concomitant NMO. So you're not the only one, but this is a very, very important observation. It also says to you what you have for 5 or 10 years doesn't necessarily militate against having something different, but targeting our particular areas of interest, particularly the nervous system. We are coupled to oncology and infectious disease, and we need to think that way.
I absolutely agree, and we, part of the idea of incorporating more of the concept of immunosenescence in our practice is, that's exactly what both of those fields have done for a very long time. So that's very well said, and I think it's also a very important pearl to say, just because you live with MS, you don't want everybody assuming everything that happens to you is from your MS, and this is pretty extreme example of that. We are completely up against time, but this
okay, I just have
absolutely fascinating. But Carolyn, I know you have other slides you prepared for this. Is there one or two you want to make sure we get to look at?
Not really. We can just, go. So this was just all my moments of extreme panic throughout her course. It was just nonstop. So just to wrap up, she still is very weak. She's able to move her right arm a little bit. She has a lot of spasticity, but she also has all these transportation difficulties getting to Botox clinic. We're considering her continuing her Ocrevus, and currently both the patient and the family and this fellow have all been traumatized by this case. And, just describing to the patient and her husband, what happened was really challenging, especially when, I'm not sure if she had NMO this whole time and it was misdiagnosed of MS, or she really had MS and then transitioned to MNO. And I mean, luckily the medication that we had previously chose can also be used in NMOSD. So that was kind of the easiest part of this, but honestly, just an overall challenging case. And then I think the questions and thoughts I have on the next slide, we pretty much went through everything. what was this? But I guess moral of the story for me was, never relax when you have these patients. And I mean, I'm of the practice now of always checking spinal cord imaging, even if the patient has been, stable with MS for 30 years and never had their spinal cord checked, because I wonder if that had been checked earlier, maybe we would have just sent, the CDS1 panel based on just her old spinal cord lesions. Or not. I'm not sure. And then I just had a couple slides about like the MS versus NMO brain lesions and the pathology of them that I found, but we don't have to go over those. But the difference between the complement deposition.
Carolyn, I have one comment, and it was related to Scott Newsom's comment about you need to be very patient and continue to be involved and have hope and energy and make sure your patients know about this. There's been some work to suggest that in an MS case where a deficit occurs, there's plaque and the level of recovery is not the same as you might have in somebody with NMO with just treacherous, bad-looking cord, but yet with rehab and control of the disease process, they can actually mount quite a recovery. And there's some literature to suggest that astrocytes in MS, where this is really a gliotic disease, produces an inhibitory factor not allowing peripheral Schwann cells to come into the CNS, whereas in an astrocytopathy like NMOSD, where you're killing those astrocytes, it appears that we have some capability, I know it's bizarre, for Schwann cells to actually move to those locations. This has been demonstrated, and they have the ability to at least myelinate those cylinders those axon cylinders at risk, which may allow you to run. I've seen people whose spinal cord looks like dental floss. They've lost so much caliber, and they get up and walk across the room. And you ask, how do they do that? Yeah. So I think there are quite surprising recovery. If you follow these patients long enough, and I see many patients have these devastating events. You treat them, plasma exchange, steroids, get them on an agent that look terrible, but keep going with the rehab, do the surveillance, make sure they're getting everything they need, protect their skin, nutrition, all of those things. You can see quite remarkable recoveries like I don't see when people have devastating deficits in classic MS, inflammatory demyelinating disease.
Yeah, I hope so. I hope she has some more recovery.
I'll just make a couple of really quick comments. So extensive lesions on brain MRI can happen in NMO SD. There are a number of publications out there, albeit small case series, that have shown that in the temporal course at which you see these lesions on MRI develop, it's not clear, but that can occur. In terms of skip lesions, you can see that in, depending on the case series, 10 to 20% in NMO. So and your sort of point about imaging the cord early, I'm a fan of doing that, regardless of what the underlying process is, neuroimmunological process. However, early on, you may still see skip lesions with NMOSD. Not that that should sway you from not checking, the antibody tests. I think a lot of us end up doing, even in cases that look like MS. And the last point is, someone had asked about age of onset, where you start thinking about paraneoplastic NMOSD. I think there are small case series out there, mainly by the Mayo Group, over the age of 50. If you see someone present with NMOSD over the age of 50, then you need to really strongly consider paraneoplastic, especially if it's not sort of in a African-American Black race, because we know that there's a higher predominance of NMOSD in female Black race or African-American race. So shut up now.
Those are great points. And I don't know, Scott, or if anyone else would agree, but I've had a few NMO cases with pretty impressive callosal lesions, which can also throw people off. They look a little different to me in the cases I've had than your traditional Dawson fingers, but sometimes that can throw people off, even me, in terms of looking at somebody with a high callosal lesion burden, that even your radiologist is going to say this is MS because look at all the burden in the callosum. So in the interest of time, and only because of the interest of time, I think we'll wrap up here. Fantastic job on both case presentations today. Fantastic discussion. Really appreciate everyone's contributions today. Scott, any other final comments? I thought both cases were really well done and great topics.
No, they were fantastic, and we try to be on time, but I think this warranted a little extra time. You both did fantastic, and certainly I learned a lot, so I always appreciate that.
Yeah, thank you guys. Thank you, Hope, for saving my presentation.
Thank you, everyone.
Thank you, everyone.
Can I confirm we're on for June, Scott and Hope? I can't remember because this is my first year, if we do June or if summer starts in June or July.
I believe summer starts in June. I think this is the
Yeah, I
last
think
one.
This is it?
Yes, this is it.
Oh, okay. We forgot to, throw up the fireworks at the end then. Okay.
That's what I remember too. May was it. Is that right, Elliot? Yep.
That's correct. Yep,
Is that
September.
okay? I wasn't sure. I don't have the
Okay.
schedule in front of me, so.
And then we tried to put in something in the middle of the summer for 2 of our 3 years. So, but the set schedule is September to May inclusive, and then summer's off unless we have a special session, which we have had in the past.
All right, we'll have to send out a fireworks congratulations message for all the graduating fellows by email then. So
Yeah,
fantastic.
You guys all
Thanks
did
to everybody.
fantastic. You guys, the cases presented this year were incredible, and we thank the Fromans and Dr. Zamville to allowing us to be involved at this sort of intimate level. It's been fantastic. I think, at least for me, I can't speak for you, Jen, but we've really appreciated being involved at this level. It's been incredible.
You guys are great chairs, and I would say that the program is better than it has ever been because of the Newsom Graves discipline on the sequence, seriously, from fellows to the faculty. I think that's really engaged the fellows this year more than any other year we had, including the 3 years Teresa and I did it. So I think imposing architecture on this is very, very important. And you see me, I'm even raising my hand now. This is like a good thing.
I know, I can't believe it. I can't believe it. We did our job. We did our job.
Old dogs can learn new tricks. That's part of being the chameleon.
Well, thanks so much for including me in this year. I really enjoyed it, and congratulations to all the graduating fellows, and good luck over the next few months.
Thank you. Have a great summer.
Great. Thanks,
Bye.
everyone. Have a good night.